Greetings everybody, here we are again on Friday. It is Friday right after World COPD Day, right in the heart of COPD Awareness Month. My name is Mike Hess and we are here on COPD Navigator Live, our weekly look into the world of COPD and events and everything else that you need to know to effectively manage your COPD or that of a loved one. For those of you who may be new to the program, we do this every Friday. We are, like I said, we do a half hour of various COPD topics. This week we're going to be looking at breathing techniques and a few other odds and ends. And then we also have a good half hour or so of question and answer time. This is your chance to get some information that you can then take back to your medical provider and make sure that you are getting the most that you can possibly get out of your COPD management plan. So today we're going to start, as we always do, with a little look inside some of the latest news of the week for COPD. And of course, this, as I mentioned, this was a big week for COPD on an international scale. This was World COPD Day back on Wednesday, which was a great opportunity for the COPD community around the globe to come together with awareness events and spirometry screenings and all kinds of fun stuff to help raise public awareness of COPD. And clinical execution of how we're doing, of how we're managing COPD and how we're treating it throughout the continuum of care. Of course, also yesterday was what's called the Great American Smokeout here in the U.S., which is always the third Thursday in November, and is a fantastic opportunity to try to kick the habit. Of course, smoking causes roughly 75 to 80% of the cases of COPD that are out there. So of course, if we can limit the exposure people have to tobacco smoke, that is a good thing down the line. The question kind of becomes, are events like that very effective? And the answer seems to be yes, to some degree or another. We see that anytime we have any kind of encounter from a clinical standpoint, anytime we have an encounter with a person where we can talk to them about quitting smoking, it does increase the chance that they're going to cut down on their cigarette use and therefore reduce their risk to some degree. People may not necessarily quit right away or quit at all, but if we can get if we can cut consumption, if we can increase the chance of quitting, then we can sometimes make a difference. A recent study from San Diego State University showed that when we have these big public awareness events like the Great American Smokeout, we see Google searches for how to quit smoking and things like that go up about 25%, and calls to quit lines go up a good 40 to 42%. Here in Michigan, we have a I believe it's a 1-888 number. No, we actually still have a good old-fashioned 1-800 number. We have 1-800-QUIT-NOW, which can connect many of our citizens in Michigan to smoking cessation strategies, nicotine patches, nicotine replacement therapy, and that sort of thing. Many, if not all other states have a very similar thing, and of course the COPD information line at 1-866-316-COPD. I always forget that one, so I have it written down. They can connect you with some of the resources that are available in your state. The other big topic that we have for COPD news this week is a new study that got published earlier this week out of China, the Shanghai Pulmonary Hospital to be specific, that looked at smoking and COPD group for about 5 years and found, perhaps not very surprisingly, that those people who were in the group that quit smoking, which was about half of the patients that they studied, had lower mortality, which means fewer of them died during the study time, and had higher spirometry values, particularly the FEV1, or that forced expiratory volume in the first second when you're blowing out, that big spirometry test that is often used as a benchmark for COPD diagnostics and trying to figure out how severe your case is. So you basically, the upshot there is if you quit smoking, you are less likely to die during a study period, and you have better overall lung function. One of the other key endpoints of that study, which may sound a little bit strange, was that people who quit smoking had COPD for longer. They had longer cases, and which may not necessarily sound like a good thing at the beginning, but if you realize that if you have COPD for a longer time, then you're living longer, then that can also be a benefit. So in honor of that, and because we have relatively low other news out there, I want to take a few minutes before we really get into the breathing techniques to talk about smoking cessation, tobacco cessation. We have a lot of words for it, but basically it's trying to get people to quit smoking. There are a lot of different strategies out there, and the key thing is for people who are smoking to quit as soon as possible and to find the right strategy that works for you. A lot of times we as clinicians kind of look at this thing as, well, we're going to tell you to quit smoking, we're going to give you all this evidence, and we're going to, maybe we'll give you some pills or we'll give you something else to help you quit, and that's that. But what we really are seeing now is a shift toward treating this as more of a chronic disease like COPD itself. Once you quit, you are going to have to continue quitting for the rest of your life. We don't want to see any backslides. We don't want to see people retaking the habit after they quit, because again, those things are problematic and reduce or increase your risks down the road. And so how do we do that? Well, I like to look at smoking cessation as a lifestyle change. You know, a lot of times, as I said, we're very quick to give you a patch or give you some gum or even give you one of the pills that are out there to help increase your chance of quitting. And those are exceptional tools, don't get me wrong. But I think sometimes we rely a little heavily on that as opposed to trying to look at some of the psychology of it. And so in my practice, that's what I try to do. I try to discuss habits and the rituals and a lot of those things out there. And as Susan points out, one of the things I really like to do is celebrate those victories. Susan shares with us that she quit smoking 561 days ago, which is fantastic, and congratulations to you for doing that. I hope you enjoy another 500 or many, many more days of being smoke-free. We really need to emphasize that because quitting smoking is a massive achievement. I was not a smoker myself. I tell people I'm a snacker. I used to weigh over 360 pounds because, as many people do, I ate as many people smoke. People like to do, they smoke around friends, they smoke when they're bored, they smoke when they're upset. I did all those things when I was eating. That was my habit, just like smoking becomes a habit or kind of a ritual from day to day. And so we need to work on replacing those rituals and replacing those habits with things that are a little bit more healthy. And so one of the things I talk about is the power of distraction. We found that a lot of times if you have a smoking craving and you can break that for about 5 minutes, you'll get distracted by something and life will move on, and then you won't have that cigarette. And so I like to give my people a list of things that they can use to distract them. Whether it's as simple as playing a game on your phone, doing a jigsaw puzzle, working a crossword puzzle or a search word, something like that, or something maybe a little bit more intense, or what some people call maybe a little bit more goofy, like going into your room, turning the volume up, and just having a little dance party for a few minutes, going for a walk, going out, doing some cleaning, writing lists about why it's so great to not smoke. There are things that you can do to kind of combat that craving, change that distraction from you, and then by the time you know it, either you're caught up in that activity or something else has interrupted you now you need to go on and continue on with life, do all the other things that you need to do, and the next thing you know, it's been a couple of hours and you haven't had that cigarette. It's not necessarily something that is going to be one of those things where you just quit because you're distracted and you never think about it again, but every fewer cigarette that you smoke is beneficial to you. Along those same lines, I talk about the psychology of the habits and the rituals we build up alongside the smoking. One of the things I see a lot is people, particularly in the morning, they'll have their cup of coffee in one hand and they'll have their cigarette in the other hand. And a lot of times you may be trying to quit and you'll have your coffee in the one hand and your other hand will be empty. And there's that little bit of that animal brain we have there back from the cave days that doesn't really know what's happening. It knows that something is different. It knows it doesn't like it, but it can't quite put its finger on what it is. And so we see a lot of times you'll just kind of be jittery and you'll be upset and you won't know what to do. And then all of a sudden your regular brain says, oh, I don't have my cigarette. I'm going to go get that. And you go get your cigarette and you light it up and you start smoking, and then all of a sudden everything is happy again. You get that kind of endorphin brain chemical reward flush, and you think everything is happy and it feels like you're actually relaxing. But one of the weird things is nicotine in cigarettes is actually a stimulant, so it shouldn't make you relax. And that's how we know that the psychology of this stuff is arguably even more important than the chemical physiology sometimes. So what I do is I give everybody a little kit. First off, I give people a little straw that I've cut up to about the size of a cigarette. And this is something, actually I give them several. I give a little Ziploc bag that's full of these things. And this is something that you can have in your hand, you can have it in your mouth, you can bite on it, you can puff through it, you can do all the stuff that you do with a cigarette, except you don't get the tar, you don't get the smoke, you don't get all the chemicals, you don't get all the nasty stuff. This helps stimulate those reward centers in your brain and gives you a lot of those same habits and a lot of that same ritual reward that you are looking for with a cigarette without all the bad stuff. Now, because these things aren't necessarily the most sturdy things in the world, sometimes people like to bite down on them and things like that, I also give out coffee stirrers. These are still, you can put them in your mouth, you can put them in your fingers. It's not quite the same size, not quite the same shape, but they're a little sturdier. You can bite them, you can chew them, you can do all that kind of stuff and get that oral fixation reward that some people crave from the cigarettes. They're also very flexible as far as what you can do with them. I've got one person who just likes to wrap and unwrap them from around her finger. The key is finding something that distracts you from smoking and helps keep your other appendages, your mouth and your fingers and all that stuff busy so that you don't get caught up in that psychological reward. I also give people a little thing of Play-Doh. This isn't necessarily something that you can do to replace smoking, obviously. Some people like the smell, but I wouldn't suggest lighting it up. But it's something you can do with your fingers. It's something tactile that you can do. You can distract yourself with it. You can play with it. It's a great conversation starter. I've had a lot of people tell me that, they'll go, instead of their buddies will be smoking, and instead of going for a cigarette, they'll get their Play-Doh out, and everybody will start talking about that, and then they can share with that, and then, again, it's a distraction tool. So they have a little quick kit with the straws, the coffee stirrers, and the Play-Doh, and it's fairly effective. I'm not going to tell you it's foolproof, but it is an excellent method that a lot of people have used to cut down and in many cases even quit smoking altogether. We hope to be able to maintain that in the long term, of course, but as I said, whenever we can cut down on that amount, we're doing a good thing. So that kind of leads us into what happens after the fact. And if you haven't been able to quit smoking, what are some breathing techniques that you can do to manage your COPD all right? Of course, we do a lot with medications and things like that in order to clear out a lot of those symptoms. But of course, many of the symptoms of COPD are resistant to some of these medications, or there are times where it's just not practical to take those medications. And so we see that there are different breathing techniques that you can do to help relieve some of these symptoms or that sensation of breathlessness and try to get back kind of on the straight and narrow. I've seen a lot of people who say, my oxygen level is fine. I get my oxygen level checked all the time, or, I have a little pulse ox at home and I measure it all the time. That's fine. So why am I short of breath? And the reason is because I had to laugh a little bit. Darla, who is a member of our group here on Facebook, COPD Navigator, is looking for some dance moves. If you are looking for some dance moves, I'm not going to do any today. I'm sorry to disappoint. However, there is a place you can go. Last year I did a series of videos to try to raise some money for the COPD Foundation during COPD Awareness Month. That were called Lip Sync for Lungs. I did a variety of different songs and different genres, and there were definitely some dance moves out there. If you go on YouTube and you look up Lip Sync for Lungs, or if you search for COPD Navigator, a lot of them come up from there too. You can check out some of my fresh moves from last year. However, back to the question at hand: how are we going to relieve some of these symptoms of breathlessness, even when your oxygen level is good? One of the biggest things we see is that people with obstructive lung disease, if you think about your lungs a little bit, we have these air sacs in there called alveoli. It looks like a big cluster of grapes. And that's where the good air comes in, the oxygen comes in, goes into your bloodstream, and the carbon dioxide comes out, and you breathe it out as your exhaled gas. Of course, those grapes, those alveoli, those have little airways that connect them up to your bigger airways and eventually up to your trachea and out into your mouth. And we see that with a lot of cases of COPD, we see that some of those very, very small airways actually collapse down a little too quickly. And unfortunately, that traps a lot of the stale air in the alveoli, and it doesn't let that carbon dioxide go out. And your body can sense that buildup of carbon dioxide, and it wants you to breathe faster. And that's what is interpreted as your sensation of breathlessness. You're trying to breathe faster to blow out all that stale air and get fresh stuff in. We found that there are a couple of techniques, one in particular, that can really benefit or really help you get out some of that stale air. The first one we're going to talk about today is very easy. You don't need any other tools. You don't need any special equipment or anything like that. It's called pursed-lip breathing. And hopefully many of you are already familiar with this, but we'll do a little bit of a refresher here. If you're not familiar with pursed-lip breathing, it's very simple. You take a breath in, usually it's said through the nose. Fill up your lungs as best as you can. And then you blow out, just like your the best analogy I've been told by somebody with COPD is you're trying to cool off a spoonful of soup. You're basically putting your lips together and blowing like that famous movie line, but you're not quite whistling. I suppose it's not a bad thing if you whistle, but usually you're just trying to blow out all that air. Kind of a nice smooth exhalation, and what that does is that when you purse your lips together like that, it gives you a little bit of resistance to breathe out against, and that resistance gets transmitted all the way back down into those very small airways, helps keep them open, and actually flushes out a lot of that stale air a little bit better. So again, pursed lip breathing, you're basically taking your breath in and blowing it out. A lot of people have mentioned that their providers have talked about smelling the flowers and blowing out the candles. Whatever metaphor you use is a great one, but the physiology of it is going to remain the same, and you're just going to breathe in and blow out. The next big thing as far as a breathing technique goes is what we call diaphragmatic breathing. And a lot of times, we see that it's very easy to kind of get hunched over a little bit and just kind of when you're struggling to breathe. One of the things we look for, they tell us to look for in respiratory school, is this thing called the tripod position, which I don't know that I can demonstrate really well, but if your torso is one leg of a triangle, your other two arms are kind of the other leg, you're usually leaning against something, you make kind of a triangle or a tripod in order to support your lungs and breathe, because it's very easy to kind of get bent over and not allow your lungs to expand very well, because you're trying to use all the muscles you have in your chest to make that stuff expand. So we have this idea of diaphragmatic breathing, where if you kind of sit up a little bit higher, you kind of try to keep your abdomen, your belly, try to keep that as stable as you can. You can kind of reinforce it a little bit, and you're really trying to breathe just with your diaphragm, moving that up and down. And again, for a lot of these things, there are some other demonstration techniques and that sort of thing available through YouTube and through other sites. You can get perhaps a better example or more one that you can kind of slow down and rewind and fast forward and all that kind of stuff. But the thrust of that is to make sure that you're expanding your lungs as big as you can, which can be difficult with COPD, and making sure that you're filling them up as much as you can, and then again using some of that pursed lip breathing even to expel a lot of that stuff out. So that's what we talk about when we're talking about breathing techniques. But of course, again, a lot of people with COPD have a lot of trouble with mucus, phlegm, the yucky stuff that nobody likes to talk about. So how do we get a lot of that stuff out? Because that can cause a lot of breathing issues in and of itself. A lot of times people will get into those big coughing fits and get very tired and still not be able to clear out a lot of that stuff. And first and foremost, we want to make sure that you are hydrating properly. Now, of course, a lot of times with COPD, we see other conditions like congestive heart failure and things like that, where you have to somewhat limit your fluid intake because you have other concerns going on. And of course, before you change any of your dietary habits, including your water consumption, you're going to want to check with your provider to make sure that this is safe for you. But we want to make sure that you're at a fairly good level of hydration so that mucus is as thin as we possibly can make it, because the thinner the mucus is, the easier it is to bring up. Once that's done, of course, we do want to see people being able to clear that stuff. And when you get into those big coughing fits, and when you're coughing, you get tired, you get sore, you get a lot of stuff going on. And so sometimes it's better to have a more efficient cough rather than a stronger cough. And so a lot of times we do this thing or we teach people to do this thing called huff coughing. And again, fairly simple. You don't need a lot of specialized equipment for it. It's basically where you will take a breath in and you'll kind of huff it out at various frequencies. It looks a lot like this. See, it works. A lot of times you'll do that huffing, and if you vary up the frequency, the different frequencies and the different depths of the huffing help clear out the different levels of the airways inside of your lungs, from the very small ones that are right next to the alveoli to the bigger ones that are closer to the main stem bronchi and to the big trachea. And again, what you really want to do with these is those will help move some of that mucus up toward the middle of your chest, where it's going to be, you have bigger airways to contend with, and you're more able to clear some of that stuff out. So you do about 3 to 5 rounds of that, and then you do the more traditional cough, like I inadvertently demonstrated, but you do that more, and that way you're giving yourself a better chance to get out more of that stuff. You're making your cough a little bit more efficient rather than just stronger. We have this idea where if we can just bear down more and we can just really oomph it out, we'll just clear all that stuff out. And unfortunately, that's not quite how it works. However, sometimes even the huff cough isn't going to be enough to clear out a lot of that mucus and clear out a lot of that junk in there. And that's when we do need to call in some of the more specialized equipment. We have a couple of tools. Actually, we have several tools available on the market. I happen to have 2 in my office here to demonstrate. This one has been on the market for a little bit longer. A lot of people call it the pickle because it's green. It's got a couple of different shapes and colors to it now. The brand name is called the Acapella. And what this device does is, you can see a little bit here, this is a restrictor panel in here. And it also has a little bit difficult to see in this particular model, but there is a vibration element in here also. And what this does is when you take a breath in and blow through it, hopefully you can hear that kind of rumble, that vibration in there. It does a lot of the kind of thing of huff coughing, except it's obviously a lot faster, and it vibrates that column of air all the way back down into your lungs and literally shakes loose some of that mucus. We have also a tool called an Aerobica that does a very similar thing that I like to bring out because this one comes apart and lets you see the components a little bit better. I will point out, for the sake of full disclosure, I do not get endorsed or reimbursed by any of these companies, and their devices are presented here simply for demonstration purposes and should not be construed as an endorsement by myself or the COPD Foundation or anybody else, but more simply a demonstration of these concepts. And so you can see from here what happens is as you blow through the device, this vein kind of goes back and forth, and that's what causes the vibration. If I put the thing back together here, you'll see that if I blow through here, it's very similar to as I was blowing through the acapella. Again, gives us vibration and some resistance to help prop those airways open, just like with the pursed-lip breathing. Gives us the vibration, just like with the huff coughing, and helps shake out a lot of that stuff in order to knock it loose. There are a couple of other tools out there on the market. One of them, I believe, is called the lung flute. There's the traditional PEP valve, which is just the resistance. It doesn't have any vibration to it. There's literally a dozen or so different things out there that can help with these things. And they work either on the concept of resistance, the concept of vibration, or a little bit of both. Whatever happens to work for you is the best tool. The biggest determinant here is if you have a lot of mucus, one of the vibration devices is going to work well for you. If you have mostly the airway obstruction, where you have maybe a dry cough and you're not bringing up very much, then perhaps just the airway resistance will be sufficient. Stepping up from those devices are actually vests that you can get to put on. I know a few people in my Facebook group, COPD Navigator, swear by these vests. These are basically kind of give an external variety of the vibration that you can get from the aerobica or the acapella. It's a vest you put on and it inflates with air and actually vibrates your whole chest and your whole thorax here, and clears out a lot of stuff that way. The downside to those is they are, of course, a lot more expensive and a lot less portable than something like this that you can kind of carry with you in a pack or a purse or whatever you have with you. Those devices aren't really portable. They stay at home with you and you do a couple of treatments a couple of different times a day. Those are also can be a little bit difficult sometimes to get reimbursement for them. You have to have generally the easiest way to get that is to talk to your provider about whether you are at risk for a condition called bronchiectasis, which is a very underdiagnosed form of COPD, in which some of the mucus actually takes up shop and gets infected and all that stuff inside of your lungs. Diagnosing bronchiectasis usually takes a CT scan. It's got a fairly distinctive appearance on there, but that kind of opens the doors to a lot of other reimbursement things for things like these therapeutic vests and that sort of thing. The last thing I want to talk about today is something that is a little bit unique and a little bit special to the COPD Foundation itself. Of course, we've talked a lot so far about these techniques, these devices that allow you to blow through them and create these different flows. And as the parent of two marching band students and a younger student who's playing the saxophone in middle school now, of course, one of the many ways we make music as humans is through the use of blowing air. So there is a lot of music therapy that can be very beneficial to those with COPD. And a few years back, actually about a year and a half ago, the COPD Foundation partnered with the Academy of Country Music to develop a program that uses harmonicas to enhance lung health and to improve those symptoms and enhance quality of life for people. The foundation calls this program Harmonicas for Health. And earlier this year, I was fortunate enough to see a demonstration by Stephanie Williams, who, if you were on the COPD webcast, COPD Foundation webcast this past Wednesday, you got to meet Stephanie. She talked a little bit about the Harmonicas for Health program. But she taught many of us how to play the harmonica and talked about her experience in setting up a lot of these programs and the benefit that they have had. And so we have a little form here. Let's see. I just want to make sure I'm hitting all the pertinent points here. Playing the harmonica simulates pursed lip and diaphragmatic breathing to give the person more control over their breathing and help clear their airways, which makes sense. As you're blowing through an instrument, you have a very controlled breath. You have some resistance, and you're taking a deeper breath to try to do that diaphragmatic breathing and control that stuff. In the various pilot projects that the foundation has been involved with, it says that people have been delighted with the positive impact on their lives, and they asked a series of questions. And 65% of people that in these pilot programs said that they had more control over their breathing since playing the harmonica. 62% have been more social. 50% have been more active. 50% have had more confidence. 42% have had a better ability to cough up mucus. And about a third have had less stress and, perhaps most importantly, less shortness of breath. So this is an excellent technique, an excellent device that you can use while it's not deviceless and you can't necessarily do it everywhere. These things are relatively cheap. You can go get a decent quality one, I believe on the order of, I can't imagine these were super expensive, but $10 or so. I think I was even recently went to the House of Blues in Chicago And they had special House of Blues harmonicas that were very similar to this, that were even with their branding on the order of $10 to $15. So it doesn't have to be anything fancy, doesn't have to be a professional level harmonica, just has to be something that you can breathe through. And what I will do is, because I'm sure I let a lot of people down earlier by not being ready to dance, I will do what Stephanie taught us how to play in Tennessee when I got to learn from her earlier this year. We learned how to play Twinkle Twinkle Little Star. And so, without further ado, that is Harmonicas for Health. Hopefully you can pick out that was Twinkle Twinkle Little Star. I'm going to throw a link up here real quick to get to the Foundation's Harmonicas for Health program if you want to talk to some of the people in your area to set up this type of program in your area. The Foundation is very willing to work with pretty much any group, whether it's a Better Breathers group, whether it's a clinical group where you want to get this, you want to talk to your pulmonologist or primary care provider or your local friendly respiratory therapist to get them started on a thing like this. Again, it is very easy to do. It is very social. A lot of people have the opportunity to meet friends and get to know each other a little bit better. I can tell you that this summer at COPD 10 USA, a conference in Chicago, I had an opportunity to meet and play with a harmonica group from the Chicago area. We did a tribute to the late founder of the COPD Foundation, John Walsh, and played Amazing Grace, learned how to play Amazing Grace on the harmonica. And I can tell you, after speaking with those people, in particular, firsthand experience, it's an incredible program, and I encourage everybody to, if nothing else, go get yourself a harmonica and have a little bit of fun with it, and hopefully set up a group in your area. So, we have talked a lot today about how we can improve breathing through the use of techniques like pursed lip breathing, diaphragmatic breathing. We've talked a lot about clearing out secretions, clearing out mucus, all that junk in your chest with huff coughing, with our different tools like the acapella, or some people call it the pickle, again because it's kind of greenish. And we have talked about harmonicas for health and making sure a harmonica or your instrument of choice can help you reduce your symptoms, increase your quality of life, and have a little bit of fun while you're managing COPD. So with that, we are ending the schoolhouse portion of the program today. Again, for those of you who are maybe not familiar with COPD Navigator Live, this is something I like to do every week. We have a half hour of a topic, and we have a half hour of a question and answer period. So I invite everybody to start adding some of their questions down there. We're going to scroll back through and get some of the people who already joined us and catch up on some of that stuff. I'd also like to throw a plug out there. My personal group here on these COPD Navigator Live sessions came up from a COPD information and support group we have here on Facebook, similar to the Foundation's COPD 360 social network, except it's here on Facebook. Our group is called COPD Navigator. You can search Facebook for COPD Navigator or join us at facebook.com/groups/COPD Navigator and join our conversations over there. We have a fantastic community where we have a lot of people who are willing to share their journey and give the tips and tricks that they've learned along the way on how to manage a lot of these symptoms. We talk a lot about medications. We talk a lot about pulmonary rehab and other therapies. And we try to have some fun while we're doing it. So COPD Navigator here on Facebook. In the meantime, please make sure you're throwing some of your questions out there. Let's scroll back and take a look at how everybody is doing. I want to say hello to everybody out there, particularly people who are saying hi. Pam, happy to see you here. Bonnie giving up her nap to join us on COPD Navigator Live. Greatly appreciate that. Bonnie's been a great supporter of our group here and is a fantastic person to get to know. If any of you are looking for a role model, so to speak, Bonnie is doing a fantastic job. Just got back to pulmonary rehab with NIAV device, a respiratory support device. Fortunately, her clinical team has been on the cutting edge of a lot of this stuff and is of great support to her. Again, we're going to celebrate, let's see, we've got 561 days quit tobacco. If you joined us late, we talked a little bit about smoking cessation earlier on. And I will point out that these videos are available through the COPD Foundation's Facebook page for an indefinite amount of time. And by next week, I get these up archived onto YouTube also. So if you can search for COPD Navigator on YouTube, you can find our older copies of these videos that are cleaned up a little bit, and I add some links and that sort of thing. Make sure everything is out there pretty good. I'm trying to vamp a little bit here while I can try to bring up a link to here we go. You can copy that right on there. Here is a link from last week's episode of COPD Navigator Live where we talked a lot about medications for COPD. But if you go on there and you can talk, or if you search for COPD Navigator, you can find a lot of those previous issues. And by request, here is a link to. This was actually. One where I was able to rope my kids involved. Here's a link to our lip sync for lungs videos from last year that we did. Like I said, I got my kids involved in that one. My whole family was in on that one. We're trying to raise some money for the COPD Foundation to try to raise awareness for people too. So if you want to see my dance moves, you can take a look at those and see what you think. Give me some feedback. Yes, Pam, absolutely, you can ask questions not related to breathing. This is open forum time, so anybody who has a question, whether it's on our topic of the day, tobacco cessation, breathing techniques, coughing techniques, whatever you want to do, throw some stuff out there, and we will get that answered. I do want to jump back a little bit here, go back to Diana, who mentioned that it's too bad Michigan doesn't have 24-hour support hotlines. That is very true. That is something that would be of great benefit to a lot of people who aren't necessarily on a traditional schedule. A lot of that will come down to money, unfortunately. We got to support our state and local legislators and make sure that they are aware of the importance of raising COPD awareness and tobacco cessation awareness. To that end, I was able to meet this week with our local representative here in Kalamazoo, a gentleman by the name of John Hoadley, working on getting the pictures from that meeting. He's had a lot of other activities this week with some other awareness events, and so working on getting those posted, but he was able to give me close to an hour of his time where we got to talk a lot about what we can do to help the COPD community in our state and our community moving forward. So greatly appreciate that. But as part of COPD Awareness Month, I encourage everybody to reach out to their legislators at every level and help bring some of these awareness events and proclamations and all that stuff forward. Rachel quitting 8 years ago. Appreciate that. Congratulations. Bill mentioning he quit. It's a lot. Bonnie mentioning remembering my quit day is easier than birthdays. It's that because it's that important. 5/14/14. And again, quitting smoking is perhaps the thing that is the most important thing you can do to improve your lung health. Patty, another one. Pam. We're trying to go in order here. Pam quit March 19th, 2012. Patty Ann quit smoking 20 years ago before breathing got bad. That is excellent. She says, I thought lungs were supposed to improve after quitting. Mine got worse over time, but really accelerated after a couple of pregnancies. Well, that is something that a lot of people mention. And the thing with that is there is this idea, this thing called the Fletcher-Peto curve, where we see that everybody's lung function kind of gets a little worse over time. which makes sense if you think about it. You know, your knee, as you get older, your knees don't work as well, your eyes don't work as well. A lot of stuff doesn't work quite as well as you get older. When you smoke, all this stuff came out of a study back in the 70s, by the way. When you smoke, it goes down a lot faster. When you quit, it still goes down, but it's going down at a rate that is more agreeable to your age. It goes back to what we call the age-related rate of decline. And so your lungs, they can sometimes get a little bit better. They get some of the stuff as far as the little hairs in there that help clear things out. A lot of those things do get better. A lot of your risk for things like heart attacks and stuff like that go down as you quit smoking. Unfortunately, we see that once you damage a lot of that lung tissue, it's very difficult to get it back. There are things that we can do to overcome that as far as exercise, pulmonary rehab, some of the resistance training to build up the muscles and to improve your metabolic efficiency and stuff like that. But it's difficult for your lungs to actually get better. And that can be very frustrating, obviously, for a lot of people, because they'll come to me and say, I quit smoking 20 years ago. Why are my lungs bad now? And it's because of that age-related decline. And so I like to try to focus on adding more life to your years rather than just straight up years to your life. So I understand that it's frustrating, and unfortunately they do continue to get worse over time, but hopefully there is a little bit of improvement in quality of life and that sort of thing also. Gail mentions her sister-in-law uses the acapella, which works great for her. That's very cool. Like I said, this has been on the market for longer than the Aerobica. This is one of the first kind of combination resistance and vibration devices that we had out there and work great for a lot of people. Those people who use nebulized medications, for both of these really, you can use your nebulizer in conjunction with this device, and they work great for a lot of people. This one seems to be a little bit easier to clean because of the way the channel is designed, but again, these are excellent tools, and whichever one works for you and you have access to is great for you. Thank you, Sam. I want to throw that out there, one of my fellow RTs out there. Appreciate the support from our RT community, especially during COPD Awareness Month. Appreciate the foundation giving me this platform for our regularly scheduled weekly programs. But and throwing back to the harmonica. Bonnie's up to 6 songs, has a Harmonica for Health program in her area. I'm sure she can vouch for it being a lot of fun and a lot of support in that area. And Cindy asks, along those same lines, would an asthma COPD overlap syndrome person be able to use the harmonica? Yes, absolutely. The whole idea of asthma COPD overlap syndrome is really getting to be kind of controversial in a lot of circles right now. We have this idea that a lot of people still have what we call a reactive airway, even in the setting of COPD, chronic lung disease, whatever we want to call it. And so it's sometimes a matter of, usually we have looked at the difference between asthma and COPD as to how much responsiveness you have to something like albuterol, bronchodilator responsiveness. But we're still trying to figure out exactly where we draw that line about what's COPD, what's asthma, what's both. And so a lot of these treatments are very similar, or they have some parts of asthma therapy are close to some parts of COPD. And as we learn more about the different kinds of COPD that are out there, we're seeing a lot more personalized care. But yes, absolutely, it's a very long way of saying absolutely you can use a harmonica even if you have this diagnosis of asthma COPD overlap syndrome. Garlic, don't know a whole lot about eating garlic for COPD, but that's cool. I'm glad that you're seeing some benefit from that. I think we're getting acts as a blood thinner. All right, I did not know that. Valerie asks a very important question. Are those devices you just showed covered by insurances? And the answer is sometimes. A lot of these things are covered with the right coding, the right documentation kind of coding. Depends on the insurance plan. Depends even sometimes in different parts of the country. Medicare has certain guidelines to cover a lot of this stuff, but sometimes those guidelines are superseded by the local Medicare carrier, so to speak. And so they have some different guidelines and different regulations and different policies for that. Oftentimes, when they are not necessarily covered by insurance, a lot of times these companies will they'll work with you. They can, much like the pharmaceutical companies, a lot of them have support programs and assistance programs to put these devices in other people's hands. And increasingly, we're seeing that health systems in general are also using these to help keep people out of the hospital. Readmission reduction is a very hot topic in a lot of healthcare circles right now, trying to keep people out of the hospital. If you go into the hospital, make sure you don't go back into the hospital, because that's not very good care, obviously. And so we're seeing a lot of places, not everywhere, unfortunately, but a lot of places are being a little bit more proactive in trying to do these programs and be a little innovative and keep those numbers down. Of course, we in the COPD community, in the clinician side of things, are constantly trying to expand those programs and get more access to them. But I urge you to speak with your local providers and your local clinicians and see what you can do about that. Cindy, yes, I am talking about regular straws when we talked a little bit about tobacco cessation earlier. This is just a straw. I'll show you. Actually, I have a whole big package of them I got from, let's see, I think these came from a restaurant supply company we have around here. They are, I got the fancy colored ones because I thought that would be a little bit more fun. I like to have fun when I'm trying to do a lot of this stuff. So the straw, you don't have to cut it. I cut it because I have the time to cut them and because I wanted to simulate a cigarette a little bit more. But whatever happens to work for you, if you want to have the big fancy, fat cat aristocrat cigarette, pretend like, like the Penguin, the Batman villain, the Penguin, have the big fancy cigar and a cigarette in the cigarette holder. Whatever works for you, whatever gives you that stimulation that triggers that reward center in your brain is what I encourage you to do. So it can be regular straws, it can be could be bendy straws, I suppose, if you want to do maybe more of like a pipe thing. But whatever works for you. Pam, all right, we finally scrolled back down and made it back down to your question. In regards to carbon dioxide, CO2, what is the CO2 on a venous metabolic blood panel? I know it is not our carbon dioxide level, as we need an ABG test to determine that. Just what does the CO2 on the blood panel tell you? Most often, some of it depends on how your particular lab will label things, but most often what is labeled as CO2 on a standard venous blood gas is actually a bicarb level. Bicarbonate is another way of carbon dioxide transport. To put it very simply, it's another way that the carbon dioxide level can be assessed inside of your blood, and so that's oftentimes what it will be marked as. There are, in certain circumstances, there are times where we will draw a venous blood gas that will give us a carbon dioxide level, but it is not necessarily very helpful for clinical purposes, especially if you are in the ER or something like that. If you're in an acute setting, the arterial blood gas is a much better representation of how your oxygen and ventilation status is, rather than the venous blood draw. So I'll put a little caveat there that it depends somewhat on labeling. Sometimes it is actually the carbon dioxide level. More commonly, it is a bicarbonate level. That can be helpful and is helpful with looking at some other aspects of your blood chemistry, but it isn't necessarily as helpful as the ABG stuff. Excuse me. So let's see what else we got here. Regular straw, cut it in half, put some cotton in the end of it. Oh, that's some engineering right there. That's a great tip from Diana. Again, whatever is going to work for you. If you want to be able to build that, you want to MacGyver something up there, then absolutely, whatever it takes to get you to quit smoking is the route that I will go. My basic philosophy, I don't know how many college football fans might be watching today, but we had a football coach here at our local university named PJ Fleck. And his big philosophy was called row the boat. And he kind of took a lot of flack for it when he first started here because our college mascot at Western Michigan University is the Broncos. And so rowing the boat for the Broncos didn't really seem to make a lot of sense. And so people kind of made fun of him for it. And so he had some very unique assessments of it. But what my biggest takeaway from him was that we are all in a boat together. You as the patient, your family and caregivers, your primary care provider, your pulmonologists, nurses, everybody involved here, pharmacy, everybody involved is in a boat together. And if we don't talk to each other and we don't work with each other and we don't tell each other honestly what we need and we don't communicate openly, at best we're going to go around in a circle. We're going to roll around in a circle. More likely we're going to flip our boat over and then we're all kind of in trouble. But if we communicate with each other, if we, as I'm fond of saying, if we meet each other where we live, if we find out what works for each other and we have open and clear expectations and all that stuff, then we can actually row from point A to point B. We can get from where you're smoking and you're not breathing so well to where you have quit and where you're doing much better. So my philosophy is my job is to give you the tools that you need to be successful and to help identify barriers and break them down so that we can all get from point A to point B and we're all doing a little bit better. So Cindy points out, quit smoking 6 years ago, went from stage 1 to end stage in those 6 years. Well, that is another bugaboo of mine. We talked about that a couple weeks ago when we first started. We did COPD basics. I am not at all a fan of the concept of end stage. I think that's silly, and I think we as clinicians do people a disservice when we start throwing that out there. It used to be that we felt that COPD was a pretty straightforward progression where you started at one point and it was kind of like the reverse of that mountain climber guy on The Price is Right. You just kind of went straight down. We're seeing more and more that that's not the case. You can have ups, you can have downs, you can have stair steps, you can have, it just depends on your individual case. Some people go down fast, some people don't go down at all. Some people, we used to do this staging based on your spirometry. That's where we got this concept of stage 1 through stage 4. Based on, you heard me talk earlier about that FEV1, when you do your spirometry test and you go, the amount of air you blow out in that first second is your FEV1. The less of that you can get out compared to a predicted value based on your age and your height and all that stuff was theoretically a measure of how bad your COPD was. And in some circumstances that remains the case, but we're also seeing that that doesn't have a lot of bearing on your exercise tolerance, your activity tolerance, your symptom burden, or any of those things. So we've kind of gotten away, and if we look at the latest Global Initiative for Chronic Obstructive Lung Disease strategy, we've almost gotten away entirely from looking at the staging based on your lung function and looked at more of it as grouping based on how many exacerbations you've had in the last year and how heavy your symptom is based on a scale called the COPD assessment test. And we're seeing that targeting treatment toward those guidelines rather than just looking at your airflow obstruction is doing a better job at figuring out how bad someone's COPD is and guiding treatment. So I apologize for getting a little bit soapboxy there, but I always get triggered by that phrase end stage. I always hate it when we as clinicians tell people that they have end stage because we don't know when the end is. There are people who end up at stage 2, and I'll throw this out there. Excellent gentleman by the name of John Linnell, who is an advocacy captain out in Minnesota, has lived with COPD for many years. Has said that his philosophy is he took his shoes off one day and did not see an expiration date, and so he figured that he is going to do everything he could to die when it was his time. He was going to die with COPD instead of dying from COPD. And that is a philosophy that I like to promote as much as possible. This is something that we can manage to a large degree. When we have a good symptom or a good management treatment regimen, we can manage a lot of these symptoms and help you cope with them. And we are striving to make it a situation where it's a with situation. We're striving to make it a with situation rather than a from situation. Absolutely, we have a long way to go with that, but I do want to try to be encouraging and get away from that idea of end stage. So, does having caught the whooping cough virus cause permanent damage to your lungs? Could it be the cause of having COPD 10 years later? I honestly don't know that we have done a lot of studies on that. I do believe that it will cause some long-term damage, and it is entirely possible that we see what we call airway remodeling, like we do with poorly controlled asthma and those sort of things, down the road causing some of those symptoms. I don't, off the top of my head, have a 100% definitive answer for that, but it is certainly reasonable, especially if you don't have other risk factors like family with COPD, which might put you at risk for something like a genetic thing like alpha-1 antitrypsin deficiency, or along those lines. So. Renee asks a very good question that we didn't really touch a whole bunch on in the tobacco cessation talk. What do I think about e-cigarettes to help quit smoking? And the honest answer is I do not generally recommend them. We simply don't know enough or really anything about the long-term effects of these e-cigarettes. The analogy I like to use is back in I think it was the 30s. We saw people we saw advertisements for things called asthma cigarettes, because as we talked about earlier, nicotine is a stimulant and it actually can open up your airways. And when you're having some asthma trouble, maybe taking a drag off of that will open up your airways a little bit. Fortunately, then we saw about 30 years later that wasn't such a good idea to have people smoking cigarettes. My biggest concern is that we are going down a similar path with e-cigarettes by promoting this idea that they're somehow safer or less damaging than traditional cigarettes. What are we setting ourselves up for 20, 30, 40 years down the road? We just don't know. They haven't been around long enough for that. There is some evidence that they're maybe not as bad as tobacco cigarettes, but there's also a lot of conflicting evidence that we don't know what some of the chemicals that are in that vapor will do to your lungs, especially long term. So, and we also have a lot of conflicting data about how effective they are. So we might be taking this whole risk on and not showing any particular help in quitting tobacco cigarettes. So it's not something I recommend at all. Obviously, the best thing to put into your lungs is air and water vapor, and anything once you get beyond that, you start getting into some of the variable risks, and it's not something I recommend. So, Becky, congratulations on being 1 month free from cigarettes. That is fantastic. And again, I want to celebrate any milestone. Whenever somebody comes in, even if they tell me it's been 2 days since they haven't had a cigarette, I give them congratulations for that. We try to send home a little note, just something, a little tangible thing that you have done a great job, and that we as a clinic are very proud of your progress, because any positive reinforcement is a big deal. When it comes to quitting smoking, there is no little victory. They're all important. That you will quit for sure when you stop breathing, although hopefully we can get before that point. Eat bacon, live a lot longer. There was a woman, I think I saw that, lived to be 105, eating bacon every day. As the husband of a bariatric nurse practitioner, and as I mentioned earlier, somebody who has taken a little bit more interest in my nutrition and diet and that sort of thing, I can't necessarily promote that idea. I'm a big fan of bacon. I won't lie about that, but I don't know that you should necessarily eat it every day. It might be okay for the lungs, but you got a lot of other organ systems to worry about also. So what my dietitian has always told me is moderation, except with tobacco. No tobacco, but moderation with the other stuff. Also, I heard something about stem cell replacement therapy, and you can get the e-cigs without nicotine in it. First, let me address the e-cigs without nicotine. That is absolutely true, but it's not necessarily the nicotine vapor that we're worried about. It's the carrier stuff, the glycols and the ethylenes and all that kind of stuff. We don't know what the long-term effects of vaporizing those things is. So we may be setting ourselves up for, we can be avoiding the nicotine altogether, and that's fantastic, but we're also doing a lot of lung damage with some of the other things that are in those that juice, that e-juice, that e-liquid. We just don't know, and to my mind, it's not really worth the risk. If I have somebody who comes in to me and says, I'm using this e-cig to quit smoking, I'm not going to say that you're wrong and shake my finger at them or anything like that, because that's not how I roll. But I will also do as much as I can, as quickly as I can, to get them to stop the e-cigarettes also. Because again, it's not just the nicotine, it's all the other stuff in there. I'm going to talk about stem cells in just a second, and I'll make this kind of the last call for any other questions or anything else in there. Make sure we get those going here. We got a few more minutes. Stem cell replacement therapy. A hot topic lately because there are certain agencies, certain clinics that are very much pushing this idea of you go to them, they will suck out some of your adipose tissue, your fat cells, wash them down, do some kind of magic, alchemy, voodoo, whatever, inject them back into your lungs, and suddenly your lungs will regenerate. And that is, speaking of bacon, complete hogwash. Stem cells are absolutely the future of care. However, we are at least from the experts that I've spoken with over the last year, we are still a good 5 to 10 years, even from reasonable human clinical trials. There are some trials out there right now, again, doing some of these other techniques. They just don't seem to have a very high rate of success at all. There has been some suspicion that some of these organizations have paid their patients to give positive reviews. Scientific research is very complicated. If you tell somebody we're going to do these stem cells, but then you also need to eat better, you need to take your medications, and you need to do these, and then that person gets better, what has made that person better? Is it the medication? Is it the stem cells? Is it the diet? Is it moving toward the ocean and breathing salt air? We have this idea of confounding factors, and these institutes that are going out there and saying we will cure your COPD are not accounting for any of that stuff. They're just barreling ahead and taking people's money, offering false hope. The traditional term for that sort of thing is snake oil, and it's certainly not something that we can recommend right now. Most of the professional societies like the American Thoracic Society, European Respiratory Society have all issued position statements. The COPD Foundation have issued position statements strongly against these clinics, these stem cell so-called clinics, and asking for greater regulation of their claims and all that sort of thing. So my advice to anybody out there is no matter how good it sounds, remember that if it sounds too good to be true, it probably is, and save your money. So that is stem cells. Congratulations, Gary, 9 years without smoking, and Pam throwing cold water on our bacon party here. Nitrates in bacon are bad for breathing. That is true. I will admit that I didn't think of that. I get a little bit spoiled. We have an excellent farmer's market here. This is our last weekend for it, but I have a fantastic butcher who gives us a lot of nitrate-free bacon, so I don't even really think about a lot of that stuff anymore. But that is a very valid point. I thank you for bringing that up. Make sure you cut down on some of the nitrates. Dorothy, 7 years smoke-free, outstanding. Catherine brings up that trying to get oxygen, O2 is 88 a lot of the time, but not always. Trying to get insurance to pay for it. It is hard to get, but I know I would feel better. I do encourage anybody who's having trouble getting oxygen to contact the COPD Foundation. You can certainly start with the 866-316 COPD number, and they can point you to the they can point you exactly where to go. They have a lot of resources out there, a lot of advocacy efforts to help people get through the oxygen process. It is not always easy to get, unfortunately, because of a lot of I guess we'll call them the sins of the fathers. For many, many years, we did not do a very good job at accounting for things like pulmonary rehab and oxygen and all that sort of thing. And that has given administration, people at the administrative level, like at Medicare, they don't have a very clear picture about what it actually costs to provide somebody oxygen or what it costs to provide pulmonary rehab. And so we're working very diligently throughout the COPD community to try and improve those efforts, but unfortunately it does take a lot of time. And so because of mistakes that were made, sometimes as many as 10, 15 years ago, we don't have a good picture, and there's a false assumption that it doesn't cost much money to provide these services, even though it really does. And so we're working on it, but again, if you're having trouble, make sure you're contacting the foundation and other advocacy groups because they will help you. Get winded with aggressive workout. Does overweight affect pulmonary function test? Absolutely. We are learning more and more about how weight and excess weight in particular can affect COPD with inflammation and things like that. But at a very basic level, if you have a big belly, remember that your main muscle of breathing sits about right here. Your diaphragm sits right here. So if you have a big abdominal mass, your diaphragm is not going to be able to work against that very well. And so that affects how much air you can take in, and of course how well you can blow it out. It usually shows up on a pulmonary function test as more of a restrictive lung disease, but it can certainly affect your results, and affect, more importantly than just focusing on the results, it can affect your actual breathing. Especially if you eat like a lot of carbohydrates, or if you drink carbonated soda, and you have these big gas bubbles forming in your belly, and that can stop your diaphragm from going down and affect your breathing too. So definitely being overweight can affect the test, and again, more importantly, affect your quality of life. Where can you get one of these devices? A lot of them are carried by your local durable medical equipment provider. Places, brand names like Lincare, or in Michigan we have a lot of Airway Oxygen. Blanking on some of the other names, again, not affiliated with any of those companies. So talk to your local DME provider. If not, if they can't help you out, talk to your local pulmonologist. Hopefully everybody is at least seeing a pulmonologist once in a while, but they usually have a connection with some of these providers, these companies, and can get you what you need. Here in our primary care clinic, I actually have a pretty good relationship with some of these providers, and can get access to some of them, but even then it's also sometimes tricky, but we can at least start making connections. So let's see, Gary also brings up can affect things like the number. I'm not sure what the results, a little bit unclear about what you're asking there, so I don't want to make any assumptions, but if you want to retype us, we will try to get that before we wrap things up here. Great, that's what I thought my doctor said. I suppose there are going to be some clinicians out there who are going to be very kind of tunnel vision and say it's not going to, but if you look at the mechanics of it, and if you look at, I admit to having a little bit of an inside track, as I mentioned a little bit earlier. My wife is a bariatric nurse practitioner. I've gone through bariatric surgery myself, so I have a little bit more information than a lot of lung people do on some of this stuff, and we're learning that when you are overweight, and you have, especially if you have a lot of mass in your abdomen, a lot of that belly fat, so to speak, that kind of becomes its own organ almost, and it can secrete a lot of things that cause inflammation, which is really bad for breathing, and it can mess up some of the hormone balance, and we're learning that hormones can affect breathing too, and it's a lot more complicated, just like everything in COPD. It's a lot more complicated than we thought it was even 5 years ago. So I definitely would disagree that it has no bearing whatsoever. The exact degree is going to be up for a little bit of debate, depending on what your personal case is and how things work on that end. So let's see. Weight, does it affect pulmonary if you're overweight 30 or 40 pounds? Yes, I would say definitely at that scale it certainly would. So we're going to wrap things up. We got a comment from Jim and a question from Judith that we'll get to, and then we're going to start wrapping things up here. Jim, Uncle Jim and Aunt Mary, nice to see you on board here. The secret to living a long time is not to die. That's straightforward enough. The secret of not dying is to avoid exacerbations. The secret to avoiding exacerbations is to be compliant with meds, including oxygen, and staying active. Jim, in particular, is fond of telling us a story about how as soon as he was diagnosed, he went out and bought a treadmill and ended up burning out 3 or 4 of them along the way. Jim has seen pretty much every level of COPD, from being a premature infant all the way up to getting lung transplantation, both lungs transplanted. And so he has been one of my touchstones for a lot of the advice that I've tried to develop for my people here. And exercise is truly probably the biggest wonder drug that we have for a lot of this stuff. But it is also very important to stay on a good, as I say, regimen altogether, management regimen, which includes medications, sometimes oxygen, which is technically a medication. It includes exercise, it includes diet, and it includes knowledge. It includes being an empowered patient. I try to refrain from using the word patient a lot because I think as clinicians we get caught up in forgetting that our patient isn't just a set of numbers, a set of vital signs, a set of symptoms. It's an actual person. So I like to talk about being an engaged person and a partner in care. And in order to do that, we've got to have the knowledge. And that's what these sessions and a lot of the programs at the foundation put forward. And those are incredibly valuable for helping you, again, live your best life, keep your symptoms under control, and having an excellent management plan. We've got a couple other things here. Judith mentions lung cancer and COPD. Would like to know if she can exercise with shortness of breath. Absolutely. When you think about it, if you're anybody who exercises, if you're exercising with any kind of intensity, will get short of breath. Even somebody in perfect health, world-class athletes, if you watch sports, professional sports, when they do some of those post-game interviews, a lot of those people are out of breath. The difference between you and them is that you have some degree of shortness of breath all the time. But eventually it gets to a point of magnitude. You can definitely exercise with shortness of breath because that's kind of our body's natural state of being. How intensely, how much you can exercise past the point of shortness of breath is going to be individualized based on what else is going on inside of your body. And that is where we get into the whole physician supervised exercise or physician designed plan or pulmonary rehabilitation, when we get into that whole concept, where in pulmonary rehab you will go and you'll get an exercise plan that is kind of tailored for your abilities and your level. And that's why that's so important, because you get to a place where you can improve some of that shortness of breath and work out a little bit better. But definitely, yes, you can work out with shortness of breath carefully. 9 years, Gary feels a lot better than he did 9 years ago. What diffusion percentage will cause problems for you? That is, again, something up for a little bit of debate because there are people who have very good oxygen diffusion in the PFT, but still have a lot of symptoms and still have some of that airflow obstruction. When we start seeing things get down into, anytime we see a value that is less than 70-80% of what we would predict, it's cause for some concern. But exactly what will cause problems is going to depend on a lot of other factors. So it's difficult to give just a straightforward basic answer there. So last couple of questions here. Gary mentions not having the flu or being sick in 3 years since stopped smoking altogether. I used to get the flu shot, stopped 3 years ago. Have not been sick with the flu. Why, I don't know. Because you're lucky. It's the short answer. We definitely encourage everybody out there to get the flu shot and get the various pneumonia shots according to the CDC schedule, which your provider should have a record of what you had and what you need. But we definitely encourage everybody to get as vaccinated as possible because while they aren't foolproof, while there is still a risk of getting pneumonia or the flu every year, particularly the flu, they do generally lower the intensity of your illness. If you were to get the flu shot and still get the flu, you are likely to have less severe flu than if you just got it without the vaccine. So we definitely encourage everybody to get the flu vaccine every year, and then the pneumonia vaccine according to the CDC schedule based on whether you had the 13 or the 23 or just depending on some of that timing there. So our last question, and we're going to call it a session today. Ron asks, I have acute asthma. Can that eventually progress to COPD down the road? And yes, absolutely. When people have asthma, they have a couple of things. They usually have bronchospasm, which is where the muscles in your lungs kind of tighten down, your airways kind of tighten down. You have inflammation, which is where you have swelling, and you have mucus. You have the extra mucus. The biggest thing with asthma is oftentimes we see inflammation. That's kind of one of the hallmarks of asthma. And when you have inflammation over a very long time, you have this kind of what we call airway remodeling, which if you think about, if you have an area of irritation on your hand or your foot, you start building up a callus. Your airways kind of do the same thing. If you have that inflammation, that irritation all the time, you start having thicker airways. You start building up sort of a callus, so to speak, in your lungs. And when that happens, that can make those airways narrower, which means it's hard to get the air out, which is the classic definition of obstruction. So, yes, you definitely, we do see that, particularly with kids who have been diagnosed with asthma, especially if they have more severe asthma. They are more likely later on in life to have COPD and those that chronic airway obstruction. So it definitely can. Hopefully you're on a good management plan, keeping your symptoms to a minimum, keeping those asthma exacerbations to a minimum, and keeping all those symptoms under control, because that is what is going to keep you hopefully from progressing to very severe COPD down the road. So with that, we covered a lot of ground today. So I will mention that again, these videos are available for review through the COPD Foundation's Facebook page. They're also available on YouTube. If you go to youtube.com and search for COPD Navigator, got some of our older issues or older episodes on there. Join us every Friday at 1 o'clock Eastern Time. Where we share these videos. We have a topic of the day. We have a question and answer period so that you can take some of this information back to your provider and make sure you're on the best possible management plan for your case. Also invite everybody to join both COPD360.com, the COPD Foundation social media site, and our Facebook group here, COPD Navigator, which is facebook.com/group/COPD Navigator. We'll be doing one of these next week. That is the day after Thanksgiving, so go out early, get your Black Friday shopping done, and then join us at 1 o'clock Eastern Time for a post-tryptophan version of COPD Navigator Live, where we're going to be talking more about oxygen therapy and what some of the future of COPD care has to offer for us. So until then, hope everybody takes care of themselves, takes care of each other, has a very happy Thanksgiving, and we'll see you next time. Take care.